to give a very short introduction to Dr. Gulati. He is presently the chairman of nephrology, Fortis Institute of India, Fortis Institute of Renal Sciences and Transplantation. He goes to both Fortis in Vasantos as well as to the Escorts. And then he has had a lot of, credit to a lot of articles to his credit, and he has had the positions of being the, in the nephrology field, and he doesn't require much introduction. Dr. Monasis Sahu also has been coming to our forum very often, and he is presently having his clinic at Max as well as at Greater Clash, and he is fellow to it's difficult to read. I will not take much of her time, and we will follow the CNN further. And ask Dr. Josna, please continue.
Good evening, everyone. I am Dr. Josna, medical advisor, Koringar Ingerline. Firstly, I would like to welcome all of you for joining us today and giving us some precious time. So we will start with a case, followed by question answers from the panels, and after that we will have questions from the audience. So, Dr. Sahu and Dr. Gulati, sir, we have a case of a 50-year-old woman with type 2 diabetes identified 6 years earlier. She presents for an annual physical examination with HbA1c of 8.6%. She has a history of hypertension and is obese, but is not known to have had a previous CV event. She visits the ophthalmologist annually. Her medication includes an over-the-counter multivitamin, an oral hypoglycemic agent, that is metformin plus DPP4 inhibitor fixed dose combination, and a statin for known hypercholesterolemia. She is otherwise well, and the findings on physical examination are remarkable. So, I would like to ask Dr. Sahu, sir, how would you like to go forward with this patient?
Thank you so much, Josna. 50 years old woman, diabetic for the past 6 years.
Sir, आवाज थोड़ी तेज करो मुझे. नहीं थोड़ा पास करो.
Pass and slow.
फिर
Okay. So diabetic for the past 6 years.
सर वो है ना दूर ही ना रहे कोई. आज इतना करीब जरा और नजदीक
No, sir. Now, the HbA1c of 8.6%. So, as the first and primary thing is when a patient is sitting in front of me, HbA1c, so let's say 50 years, 6 साल की diabetes है, तो we require an HbA1c of at least 7%. 7%. And the first thing and the instinct that goes on in my mind is that कितना ज़्यादा HbA1c है. तो अगर ज़्यादा HbA1c है, but at least more than 1.5%. And she said that what is my approach, and already on a metformin plus a DPP4 inhibitor FDC, the simple thing is, obviously need something more, and that something more can be designed in terms of either a sulfonylurea outlet, which is starting to be missing. All said and done, sulfonylurea is still my real favorite go-to medication, क्योंकि हर problems में वही काम आती है जब कुछ भी अच्छा सा HbA1c reduce करना है. But then the point is, since with so much of seminars, webinars and interaction, it's never a glucocentricity approach itself. So we ought to ask ourselves a very simple question: कि और क्या हम achieve कर रहे हैं by just even thinking about sulfonylurea? So how do I like to approach this patient is, number one, what is it that is desired? So what is the goal? Number two, what's the choice of the therapy? Broad questions, let me touch upon it. Number three, whatever I'm doing it for the patient, can I really intervene because the patient also is obese? Something that can, so this is the common soil as a metabolic problem, कि सब कुछ obesity से ही control होगा. And the rest of the things in terms of hypertension obviously being taken care of and already on statins. So by and large, these are some of the quick things that will run in my mind, and I do understand and anticipate a bit for the subsequent questions to it, so I'll just leave it out here.
So, sir, I would also want to ask you one more thing. So, is there any further investigation you would require in such case?
Yes, so investigations for any diabetic who is sitting in front of us, apart from all those pattern of tests of classical HbA1c, doing a liver function test, understanding from the renal parameters, 6 years of diabetes, the test that I typically have to orient is to understand about the complications that is co-associated with diabetes. इसीलिए हम टेस्ट करवाते हैं. So one fundamental thing which is majorly missing across many of our patients is that they're not even going for a retina checkup almost on a yearly basis. Needs to be done. Number two is that please at least do a spot urinary microalbumin ratio. And third, being a hypertensive and almost like a duration of diabetes which is more than 5 years, a cardiac evaluation also needs to be done as per the guidelines. So these are some of the things that our test has to be oriented to understand all these 3 broad parameters.
Thank you so much, sir. Dr. Gulati, sir, what's your opinion on this case?
So Monish has already, told us as to how we approach. But for me as a nephrologist and also for a physician, when you are prescribing any therapy, it is fundamentally important to know what is the eGFR of this patient. Because therapy doses and all might be directed. There are some agents which might be included, but there are some agents which you would do upfront. Obviously, this 50-year-old lady needs a lot more to be done. So we need to know what is the eGFR, we need to know what the urine albumin ratio is before we proceed.
Okay, sir. Thank you so much, sir. Dr. Gulati, sir, I have another question for you. So, sir, a study has shown that there is increasing urinary albumin creatinine ratio and decreasing eGFR. It plays a huge role in CKD patients for progression. So, sir, in the Empalina FDC combination, the gliflozin has shown to reduce both UACR and increase the eGFR. So while gliflozin has beneficial effects on reducing albuminuria along with some soft renal benefits. So is this a good combination for type 2 diabetes patients?
Absolutely.
With renal rest disease?
Absolutely. So here we have a 50-year-old lady whose HbA1c is still sitting at 8.6. That's why I said I would first look at the eGFR, and if the eGFR is about 25, I think without batting an eyelid, that would be me. I would add on a gliflozin. So because these are, as I call them, super drugs for diabetes, because they not only control the renal axis, they do much more than that. They look at the cardio-renal axis. So you're getting a buy one, get one free, besides getting blood sugar control.
Sir, can I interject here? Before the slide is changed, I think a chance should be given to the audience also.
Yes, you should ask questions to the audience also.
With my highest regard to my friend Dr. Sahu, as he said, sulfonylurea to be added. Of course, it is very much in practice to add one of the other, I think the cost-wise or whatever, but now the costs have been reduced. SGLT2 should be preferred over SU because of weight gain as a side effect of SU, and she is already obese. Pardon me if I am wrong, I want to be clarified. Sahu, you agree?
Without any doubt.
And also, as it is written, she is being given statin for her for a known hypercholesteremia. Had it been even normal, I would have given. Because in diabetic uncontrolled, the LDL is more atherogenic, even if it is normal. Your comment, sir.
So one, it's a diabetes itself is a vascular disease, synonymous to the vascular disease. Diabetes is a coronary equivalent. We have to treat our diabetic patients as if there is every diabetic has got a subclinical cardiovascular disease. And even for the guidelines as well, anyone who is more than 40 years, anyone who is more than 40 years, a moderate dose statins is also advisable. Nothing is from every parameters.
Thank you, sir.
Thank you, sir. Dr. Sahu, I have one question for you. The global clinical guidelines has recommended an initial combination therapy for patients presenting with HbA1c more than 1.5% above the goal. So the rationale of combining an SGLT2 inhibitor like empagliflozin and a DPP4 inhibitor like linagliptin is multifold, including addressing multiple pathological mechanisms of type 2 diabetes and meeting several needs for patients with type 2 diabetes. So what are your thoughts about the earlier intensification with empagliflozin and FDC as compared to DPP4 inhibitor and metformin combination in this regard?
So first, I think most of the, if I can give you the liberal comments, I believe that most of the guidelines actually lag behind what most of us as Indian physicians already do. To give an example, number one, before even the BITS concept came up, most of us as physicians, I still remember the days when I was there at BHU. Physician was writing an insulin with a sulfur. I'm just making a context to what I'm going to answer to your question. With an insulin with a sulfonylurea, and that used to be very heavily criticized. Keep sulfonylurea there because insulin agar de rahe hain, so obviously there's no beta cell. But then the concept of it slowly came up as a guideline. It's a bedtime insulin with a daytime sulfonylurea. So sulfonylurea de dijiye, then insulin dijiye, and that is what. Secondly, even in terms of the guidelines, पहले क्या था कि guideline में you start with the metformin, फिर आगे बढ़िए, fail हो जाता है तो कुछ combination दीजिए. But I think Indian markets typically embraced and imbibed upon the classical combination of gliptin and metformin. Talk about sitagliptin metformin, vildagliptin metformin, linagliptin metformin. Everybody started almost practicing it. Then what happened is that those analogy of the verified trial came up as well, which suggested कि हाँ शुरू में भी अगर आप combination दे देते हैं. So it really takes care of the diabetes without a hypoglycemia. The time to a next treatment failure, be it a primary failure or a secondary failure, is very, very minimal. And because majority of physicians have an inertia of cascading the therapeutic armamentarium, so please start with the combination. What I'm trying to make a point is, the guidelines actually have lagged behind what we typically practice. Now, therefore, let's talk about the questions out here. The guidelines stated कि more than 1.5-1.6% पे 2 combination देना है. Obviously देना है because one of the agent will not be able to bring down the HbA1c beyond 1%. You talk about metformin. What's the ability to bring down the HbA1c? By around 1% at least. I'm talking about a garden already. If you're talking about an HbA1c 10%, you use any therapy to bring down the HbA1c by 2%. Secondly, it's not about just a number game. It's also about asking ourselves a very simple question. What are the key targets from a pathophysiology of the aspects of diabetes? Each medicine is doing what? So if you talk about in the context of DPP4 inhibitor plus the SGLT2 inhibitors, it almost touches everything. Alpha cells, beta cells, the ordered gastrointestinal motility, the ability to impact upon the hypothalamic aspect of appetite control regulation as well. And then with the SGLT2 inhibitors, the action beyond the beta cells with the extrapancreatic effect. So yes, it truly makes a lot of sense to what guidelines state, but however we must complement each other that we have been doing it already before even the guidelines set it.
Thank you so much, sir. Thank you so much for sharing your thoughts. Dr. Gulati, sir, A study has shown that in CKD stage 3 patients of Ambalina FDC with type 2 diabetes mellitus, the combination was shown to reduce oxidative stress markers along with a good efficacy. So what are your views in this regard, as Ambalina FDC has now been approved till an eGFR as low as 30 milliliter per minute?
So as I said earlier, this is a great combination, and I think over the last couple of years it's quickly moved up the ladder, and almost all the leading guidelines now advocate this as a closance as the second line therapy after metformin. They target the cardio-renal axis. There are multiple pleiotropic effects. And all this is backed by solid data. Several trials have shown. The empiric trial is notable. It was one of the first of these renal trials that showed that there was a dramatic reduction in the renal endpoints.
Thank you, sir. So, Dr. Sahu, sir, another question for you. So, the Ambalina FDC parameters, like fasting plasma glucose and postprandial and HbA1c, recently new recommendations were added on use of time and range for assessment of glycemic management. It focuses on the risk of both hypoglycemia and long-term hyperglycemia. So your thoughts on the glycemic efficacy and safety of Ambalina FDC in this regard?
Good question. Efficacy, without any doubt in anybody's mind, it is fantastic. It's really good. I mean, I'm not saying it just because Yamin is here, but the fact is, Glycemic truly takes care of most of our patients. Now, the important part of your question was related to safety. So, any therapy that we use among our diabetic patients is that no hypoglycemia, please. And I'm saying this right now because by virtue, a few days back, I was presenting a very unusual topic, hypoglycemia in the setting of hyperglycemia. And there was kind of a bit of an academia related topic. One of the slides got everybody's attention, and there is a U-shaped curve of HbA1c and the incidence of hypoglycemia. Please understand this thing. Instinctively and commonality wise, हम लोगों को लगता है कि जब HbA1c इतना strict होगा, like 5% तो hypoglycemia ज़्यादा होगा. And suppose HbA1c is around 9%, 10% तो hypoglycemia उतना नहीं होगा. That is a myth. Actually, one of a very elegant study, they just designed a very important classical graph. एक तरफ HbA1c है on the x-axis, on the y-axis the risk of hypoglycemia. So as I said, instinctively 4%, 5% इसका HbA1c हो जाएगा तो hypoglycemia ज़्यादा होगा. The risk is here. And then we were observing between 7 to 8% the risk is minimal. Beyond around 8.2% the risk was actually moving up, the hypoglycemia. In other words, what came to everybody's attention was that maybe the fluctuation of glucose also occurs dramatically, predominantly, and very importantly in the setting of hyperglycemia. And so therefore, what the integral component of every target therapy is that hyperglycemia manage to करना, but fluctuation की avoid करना. And therefore here, when we talk about the importance of medications such as a combination of SGLT2 inhibitors and DPP4 inhibitor, the fluctuation is also taken care of, and that's a very critical part of it. So you're managing a hyperglycemia without a hypoglycemia, that's the most important one. The second, broadly about the safety with the context of Glyxambi kind of a medication is that the genital tract infection, which is of course an important aspect, and this can be circumvented by a good education to most of our patients. Thank you.
Thank you so much, sir.
Just 1 minute.
Yes, sir.
Sudden fall is the cause of hypoglycemia in high HbA1c. You said around 8 also its incidence is high. Is it due to sudden fall in blood sugar at that level?
Yes. So when we have, so the whole idea was to, so those pool of population is कि दवाई दिया गया and आप देखो. So when we are talking about even by managing an HbA1c like 9% or 10%, whatever therapy was being used, when we are talking about hypoglycemia, there is of course a sudden drop of blood glucose. We are just talking about the incidences of hypoglycemia okay, incidences of hypoglycemia, which was also there in the setting of hyperglycemia. So that's important to remind us.
May I add here, sir? When there is a high level of SGLT2i, you will be giving stronger medicines. That's why you are likely to have hypoglycemia.
A very intelligent out there, sir, because the authors actually commented upon that exactly on those lines. So I just hope you were not one of those participants in those.
Thank you so much, sir. Thank you so much. So, Dr. Gulati, sir, I want to ask you that SGLT2 inhibitors, they have recorded a significant renal benefits in their respective trials. Although the efficacy might be lower once the EGFR goes down. So among the DPP4 inhibitor, linagliptin is a molecule that can be administered without dose modification in the type 2 diabetes patients with same safety and efficacy. So for a patient with type 2 diabetes and CKD requiring robust glycemic control, how do you foresee the scope of using FDC like Ampalina in such cases, sir?
So yeah, there's no doubt that linagliptin is a great value addition after obviously the glucoses, because they have proven beyond doubt their efficacy right down up to the EGFR of 25 now. So there's no doubt those are the first line drugs. But obviously in our practice we require more than one medication to control to achieve optimal glycemic control. And in that sense, linagliptin is unique. Both the Cardio-Renal trial and other trials have shown that it's a placebo-like side effects, and you can use it in the same dose across the entire spectrum of EGFR. And not only that, what I like about linagliptin is that even post-transplant, it retains its placebo-like safety, where the patient is invariably on a combination of multiple other drugs. So linagliptin is a great value addition, and you just start it on single dose and literally forget about it. Unlike other drugs where you constantly have to monitor the EGFR, titrate the dose. So those are, and yes, you get added advantage in terms of reduction of the microalbumin.
Thank you so much, sir. Dr. Sahu, sir, I wanted to ask, since you talked about genital tract infections, so how do you reconcile the vast emerging evidence on metabolic cardio-renal risk modification and weight plus BP reduction, along with potential lower risk of genital tract infection with once a daily pill of Ampalina, with the practical ease of use in Indian diabetes setting?
So I had to register the entire line of metabolic, cardiac and everything, but I understand the essence of the question being that how do we perceive the risk,
Yes.
even if we're impacting upon it. And I also truly understand that this question might be biased enough to the observation that the GTIs were lesser when the combination was used, and that's for the logic that since fungi also have a DPP4 and the DPP4 inhibitor along with the SGLT2 inhibitor when it was used, that DPP4 inhibitor also inhibits the DPP4 inside the fungi. That sounds very well, and I also understand this biasness of the question because most of you have been exposed to the classical slide deck where we see the GTI with SGLT2 inhibitor standalone and GTI with the combination, which was lesser. What till date I have been unable to gather across all my readings is a simple fundamental basis that if I have got a group A where a DPP4 inhibitor is ongoing, such as the gentle lady, and then SGLT2 inhibitor is used, versus someone who is just initiated on a DPP4 inhibitor plus an SGLT2 inhibitor, science and observation from the evidences have told us that the combination when it is used will lead to a lesser GTI. So what I'm trying to make a point is I'm unable to gather as to why when an SGLT2 inhibitor is added to an already existing DPP4 inhibitor, why were there are GTIs also. But having stated that, on a practical note, when our patients are going on to combinations like Lixambi, we just need to be cautious about GTI. The GTI incidences are never zero, and we need to be careful about it. It's an important adverse event to be taken care of, but not of such a botheration if the right kind of an advices, like a perineal hygiene, maintaining a good hydration is also passed on as an instruction to our patients.
Thank you, sir.
Can I interject here once more?
Sure, sir.
Yeah, sir, I really agree with your comments. There is a difference if you add SGLT2 to ongoing DPP4 or the reverse of it. DPP4 is added to SGLT2 ongoing. Results were seen better in case 1. When SGLT2 was added to DPP4, I am not sure what is the mechanism. If you know, please tell me. And of course, we know that DPP4 inhibitors, they will inhibit the enzymes which are used in inflammation and in immunogenic issues. So they are anti-inflammatory, of course. And the combination is even more anti-inflammatory. This is for sure. Any comments?
So I was actually commenting upon the perspective of a fungal infection, the genital tract infection, the balanitis, the vulvovaginitis. तो concept ये है कि क्योंकि fungi में DPP4 है, तो when we use a combination of SGLT2 plus a DPP4 inhibitor, so fungi का DPP4 is also getting inhibited, and therefore you do not get the proliferation of a fungi, and therefore less of a balanitis or a vulvovaginitis. So that's the context with the combination. How much that still does not explain why with the SGLT2
DPP4 is present and it is used in the cascade of inflammation, and also the chemokines. They are modulated through DPP4. If they are inhibited, inflammation will be reduced, infection will be reduced, and your immunity will be boosted. So this is also one of the corollary to our thinking, that DPP4 are helpful in containing, even we in the last meeting, Dr. Chauhan was also here. Even the ICU and the emergency use for the COVID patients.
Yes, so I think the straight parallel, drawing a parallel out here and trying to fizz off this aspect of the debate is, I believe I'm talking about the safety and taking care of the efficacy part of it. So I was talking about the GTA infection, so I think point well taken, sir.
So my point is that even in Middle East syndrome, those who were taking DPP4, they fared better, because DPP4 enzyme is required for the binding of endothelium with the virus. So it is one of the protection if you give DPP4 inhibitors. So it is one of our addition.
So I believe the bottom line is yes. So the bottom line is giving a kind of a combination with a lot of having a lot of pleiotropism is reasonably safe enough. But from all the Indian context, be very careful about the GPs. Just that's it.
Thank you, sir. Thank you, both of you, for such a good discussion. So, Dr. Gulati, sir, I wanted to ask one thing, that how common GI side effects like diarrhea and nausea you observe in patients with type 2 diabetes mellitus in your clinical practice with empalina combination, and how do you compare this FDC with other anti-diabetic drugs like GLP-1 receptor agonist in this regard?
I think I have not found a significantly higher incidence of nausea because I use this extensively now. But at the same time, I must confess, I have not used the GLP-1 agonist as commonly as to comment whether there is, it's more common or less common. Maybe, somebody else in the audience can enlighten us on it. So she is there, I think. Dr. Chauhan, where are you? So yeah, nausea and what was it? Diarrhea.
Diarrhea, GI side effects.
GLP-1 versus empalina combination. What do you think is more common?
So, we have to understand that both the molecules, as far as nausea and vomiting is concerned, SGLT2 inhibitor versus GLP-1, there is no comparison. If you were to compare, you can compare it with DPP4 inhibitor and a GLP-1 analog. A GLP-1 analog is nothing but an augmented DPP4 inhibitor. Okay? So, and what is the difference? The difference is that when you have to achieve clinically significant effects, you need to inhibit the DPP4 enzyme to a level where you can get the GLP-1 levels in the blood to 2 to 3 times the normal levels. Okay, but when you are using a GLP-1 analog, the levels are not only 2 to 3 times, they may be actually 10 times the level of normal. Nausea and vomiting is directly related to the GLP-1 levels. So with DPP4 inhibitor, the nausea and vomiting is not much. But with the GLP-1 analog, when you are using them, you can ask your patient after 1 week using 0.6 milligram of liraglutide, after a week building up to 0.9 milligram, and after another week building up to 1.2 milligram. Every single patient will complain कि डॉक्टर साहब ऐसा है कि सवेरे का खाना तो खा लेता हूँ, लेकिन जो दोपहर का लंच पैक करके देती है ना वाइफ, वो नहीं खाया जाता। सो अभी अब घर में हर रोज लड़ाई होती है कि ये दोपहर का खाना क्यों नहीं खाया। There is no appetite. Initially there will not be any appetite. So my take on this is that we should increase a GLP-1 analog if you are giving injection Victoza, for example, or semaglutide. Increase them very slowly. That is why when you are giving a oral semaglutide, I'm sorry, I'm diverging from guardians. What is important is that increase it very slowly. You have the first strength, then after a month you have the second strength, 7 milligram, and then after a month you have the third, ultimately the 14 milligram. So you have to be very, very slow building up a GLP-1 analog because you are taking the GLP-1 levels to the ultimate levels. So, as far as Jardiance is concerned, empagliflozin is concerned, there is no issue. There is no issue of any GLP-1 being, raised in the blood. It is DPP4 versus GLP-1 analog. And remember, all of you, what is GLP-1 analog? Nothing but a very highly augmented DPP4 inhibitor. So you never use a DPP4 inhibitor with a GLP-1 analog. That is the only combination which is not allowed in diabetes. Am I right, sir? Right.
What is the mechanism of nausea, GLP-1?
Sir, what is the mechanism of nausea? Great question by Dr. Mangla sir, and I knew it was coming.
So, in terms of GLP-1, they reduce the gastrointestinal motility. Where did the question come from?
Yes. So any
any of the therapies related to which can influence upon increasing the GLP-1 levels, they will always, with that feeling of bloating, with the reduction of gastrointestinal motility, they essentially would lead to that nauseous feeling. The higher the GLP-1 levels, the reduced with the motility, and therefore in the setting of, so it essentially accentuates the gastroparesis, which is already pre-existing in the setting of diabetes. The second part is, since the GLP-1, those GLP-1 which can also cross the blood-brain barrier are those GLP-1 which can be associated with more reduction of obesity. Now, since it is crossing the blood-brain barrier, is it also stimulating the chemoreceptor trigger zone for vomiting? That is a speculation, but the closest hypothesis is that it is an aggravation and accentuation of already a gastroparesis, or in terms of the marked reduction of the GI motility.
If you add on motility agents, does it reduce?
So, the practical observation essentially is that if there is anything that can help reduce the nausea or the so-called stomach fullness or the bloating, is to eat small and to avoid a fatty based food. Back to the question therefore is that, can using a prokinetics, can it really help? The practical observation is not so much.
So Dr. Gulati, you see, this is the data. I mean, SGLT2 inhibitors, it is something like that the whole sugar is passing in the urine, so that probably insulin has no place. Second thing is that reduction in macroalbuminuria and microalbuminuria. What is the mechanism? Is the albumin reabsorbed, or there is something in the pressure changes in the glomerulus, afferent or efferent arteriole? How does this reduce? And have you actually seen in your practice that patient who is having macroalbuminuria becomes micro and micro becomes nil?
Absolutely. I'll start off with the last question.
I think I'll like to clarify this question for sir. Yeah, I think it's a very, very important question for all of us. What Dr. Mangla sir is asking is that there is data from EMPA wherein when empagliflozin is being used for microalbuminuria, it reverses microalbuminuria and the benefit is to the tune of 43%. Sir is asking another important question. When you think that microalbuminuria has actually progressed to macroalbuminuria, the results are even more impressive. The benefit is to the tune of 83%. It's almost the double. That is what sir is asking. Dr. Sanjeev, your take on that?
Yeah, so absolutely I stand by it, and I've seen this in our practice, and that's why, these gliflozins are assumed the frontline, they are the frontline drugs in any nephrologist practice. Just the only caveat is that the eGFR should be more than 25. Now coming to how do they act? So as the name suggests, SGLT2 inhibitors. So they block the SGLT2 receptors which are present in the proximal tubule. What do these receptors do? We have to track. Their sodium glucose reabsorption is happening through these receptors. So if you block these receptors, you have more glucose leaking, so you get good glycemic control. You have more sodium leaking. Now the sodium travels down the tubule and it reaches the macula densa. Macula densa is, you can say, the command control center as far as the nephron is concerned, the unit of the kidney. And that sends, so you have more sodium leaking there, and that sends a signal to the afferent arteriole. Afferent is the arteriole which is bringing the blood to the glomerular capillary loop, and it causes afferent arteriolar constriction. So there is reduction in the glomerular hypertension. And in that way, it is synergistic with the ACE inhibitors or ARBs, which have all along been acting at the efferent arteriole. So what these drugs do, ACE inhibitors or ARBs, they cause efferent arteriolar dilatation.
Yes.
So they also reduce the glomerular hypertension. And if you use the two together, you get synergy. So that's how there is reduction of the intraglomerular pressures leading to reduced proteinuria. And they have a lot of pleiotropic side effects also. Pleiotropic effects, I mean. But in principle, I think that is, I wish we had one of the slides. I have a slide in my talk where it shows you all the sodium molecules, but briefly speaking, that's all.
SGLT2 is primarily controlling by constriction of the afferent artery. Because we are not adding on, as per the SGLT2, we are not saying the combination is reversing the albuminuria.
The combination, well now...
The combination is great.
Combination, no, even the combinations. Now we are talking about two different trials. We are talking about the EMPA trial, and even the EMPA kidney, I think, results, when are they out? The EMPA kidney trial?
Not yet.
Yeah, but the EMPA kidney trial was stopped midway because the results were so dramatic. Now so you have, on one end, you have the EMPA kidney trials, and then you come into the Cavalina trial. Both of them independent. Cavalina also showed that, you have reduction in microalbuminuria. If there was one endpoint that was evident is, now what we need to see is that yes, if you use add-on, that there's an indirect evidence. Yes, these two act independently because the DPP4 inhibitors act at the glomerular filtration barrier. They act at the podocytes, and that's how they reduce the proteinuria.
So it's primarily the glomerular pressures.
With the SGLT2 inhibitors, but with the DPP4 inhibitors, and this DPP4 inhibitor is not a class effect, it is actually a drug specific effect, because similar anti-proteinuric reduction that has been demonstrated with linagliptin has not been shown with any of the other gliptins.
Dr. Gulati sir, I had a small presentation just 3 days ago, and sir asked me the same question, and sir stumped me completely. Sir asked me a very simple question, that in diabetes 2 things happen to the glomerular membrane, the endothelial basement, the basement membrane. 2 things are happening. And sir, I would like your feedback also, Dr. Monasis sir. 2 things are happening. One is that basement membrane is getting thickened. Basement membrane gets thickened even in hypertension. What is happening here is, in diabetes, is that it is becoming not only thickened, it is also becoming hyperpermeable. So there is a problem in diabetic glomerular endothelial basement thickening. Now, sir asked
Not
me
only at the basement thickening, at the podocyte level also.
at the podocyte level also.
And that these drugs have been shown in rats to affect, at the podocytic level, they have shown to be podocyte protective. So that's why the proteinuria reduces with linagliptin.
So, sir,
The second mechanism is the fibrotic pathway. The endothelial to mesenchymal transition. What Sushil was just saying, that it gets thickened. The endothelial to mesenchymal transition, again in experimental animals, has clearly been shown to be reversed or retarded by linagliptin. So that's how the anti-proteinuric effects of linagliptin are there. And these is independent. So my hypothesis is that there is a synergy between the two. And if you use the two together, it's not 2 plus 2, 4, but it's 2 plus 2, 5.
Dr. Monasis, once we are taking SGLT2,
Yeah.
you are excreting sugar in the urine. Instead of 180, the threshold is 120 in the whole. Then if all the sugar is passing, then where is the role of insulin? When to start insulin with all this armamentarium we have?
So,
Why in spite of all this, we have high A1Cs?
right, so if only we wish that the SGL, so that begs the question that if the SGLT2 inhibitor is essentially leaking out the glucose, but it is never all the glucose. It's always that classical, it doesn't leak out the entire glucose, it just leaks out that 90 grams per day. And perhaps that also leads to a fundamental observation as to why SGLT2 inhibitors, the ability to reduce the HbA1c is still around 1% and lesser than that. So therefore, at some point of time, also eventually one would need insulin for a better control of glucose.
Dr. Gulati, thanks sir. You are a gem. Sir, my question is, if a patient is having uricemia, if he is a patient who is having the high levels of uric acid in the body, and the patient is diabetic, my question is, what will be the drug of choice which you will use if a patient is type 2 diabetes and if a patient is type 1 diabetes?
If you have hyperuricemia,
Sir.
so I don't think the drug, first of all, hyperuricemia, again, there are good studies to show needs to be targeted in both kinds of diabetes, whether it's type 1 or type 2. Because the incidence of diabetic kidney damage has been shown to be significantly lower if you have, if you are able to reduce the uric acid level. So I think independently in both of these you will try and use uric acid lowering agents or try and achieve relatively normal uricemia.
Sir, my question is, what will be, because sir, you are a nephrologist. See, we as a physician, we see you as the best physicians when it comes to the nephrology. If a patient is suffering from high level of uric acid and he is diabetic, so my question is, sir, what will be the drug of choice? I told you that, what will be your drug of choice?
To lower uric acid or what?
No, sir. Sir, lower uric acid is not a question. It's not a. It's a simple question. Any physician can do it. You can put him on. Yeah. My question is about diabetes. What will be the drug of choice which you will use?
Yeah, I think SGLT, if you are trying to get a studies have shown that SGLT2 inhibitors, among the range of side effects, I said they are not only called glycosuria, but one of their other advantages has been the reduction in the uric acid levels also.
So I think Sanjeev, what he is trying to ask is there any difference between the choice of anti-uric acid drug between type 1 and type 2 diabetes?
I'm not too sure, but what I'm saying is the SGLT2 inhibitors, Manish, just correct me, are there studies in type 1 diabetes with SGLT2 inhibitors? I don't think so. So yeah, so type 2 diabetes, no doubt I would choose SGLT2 inhibitors. In fact, the way the guidelines have been evolving after metformin, they are merged to the second drug. Yeah? So whether you have hyperuricemia or normal uricemia, anyway you have added on an SGLT2 inhibitor for that. But incident between type 1 diabetes, I think we still would depend upon glucostat to lower the uric acid.
Are there any other questions? I think Sanjeev has a question.
Yeah,
Sanjeev,
this was
please.
something I got received today.
We only have 5 more minutes. Dr. Monasis needs to leave because of some pressing circumstances. So we have only 5 minutes for interaction.
Just a small question. You see, I just got this something. 222 NMA published in ACE analyzed 10 trials to find out only canagliflozin reduces both all-cause mortality and CV mortality when compared to other SGLT2s.
I'm not sure what I think if you look at the EMPA-REG trial and then there is the EMPA heart failure trial, I think there was unquestionable reduction in both the MACE endpoints as well as the MAKE as we call it, the kidney endpoints. So I don't think there is any doubt that any of the gliflozins, till date there is no study which has proven that one gliflozin is superior to another gliflozin. No head-to-head trial is there. I think, and if you see the percentage improvements, they are more or less similar across the board. The only where there might be a slight difference is, the side effects. Like we saw, the cannabis study, there were a higher incidence of amputation which has not been documented in the other trials.
Sir, this is the clinic effect on this GLP-1 and GIP. Both are, you see, they increase the incretin levels. But GIP-1 is having an effect on glucagon. How is it then we say that it has an insulinotropic effect?
That's not something that before Dr. Monasis takes the stage, I would like to answer this. Both DPP4 and GLP-1.
GLP-1.
Just a minute. Let us understand this, sir. Understand the cascade first, sir. Please. Dr. Panthu, bear with me. So what do? So we know that in all type 2 diabetics, there is a blunting of the incretin effect. Okay? So what are the DPP4 inhibitors doing? They are inhibiting the DPP4 enzyme. When they are inhibiting the DPP4 enzyme, we know that GLP-1 and GIP are being broken down by the DPP4 enzyme. All DPP4 inhibitors are doing is they are blocking this enzyme and building up the levels of GLP-1 and GIP. Now these two molecules are going to act on the pancreas with two contrasting effects. The one is that both GLP-1 and GIP are going to increase the secretion of insulin from the beta cells. At the same time, they will act on the glucagon axis, the alpha cells, and they will decrease the secretion of glucagon. And what is the bottom line? So this is where you have to understand this. The bottom line is the glucose. They are doing it in a glucose dependent fashion.
So that there will not be hypoglycemia.
So that there will not be hypoglycemia. अगर पेशेंट का शुगर 70 हो गया तो वो क्या करेंगे? इंसुलिन का सिक्रीशन बंद करेंगे और ग्लूकागॉन का सिक्रीशन बढ़ा देंगे, यानी कि अल्फा सेल का इनहिबिशन कम कर देंगे. So that there is elevated hepatic glucose output. No, both are doing it. Both are doing it. GLP-1 and GIP, both are doing it. It is not that one of them is doing. Sir, your take on that, Dr. Sahu. Sir, let's hear it. Let's hear it.
So I don't have the most perfect answer. I'm really enjoying this conversation and the dialogues. It's much better than this mundane, typical slide presentation. So I'm actually essentially learning from a lot of pathophysiology. Since you talked about GIP, this must have stemmed up from, nowadays there's something called as a pharmaceutical, if I may use the word, rep-oriented science also. Sorry, and please apologize on this thing. I do remember somewhere somebody stated that this gliptin, it doesn't impact upon the GIP and therefore the hypoglycemia is less. Something like that. I have not found a scientific basis to this. Now let me talk about GIP. In a diabetes, have you ever wondered as to why we talk about GIP, why don't we talk so much about GIP? Because of a very simple reason, that just like insulin resistance, if you are talking about GLP versus GIP, now both are incretin, so therefore it is important to ask this question. In the setting of diabetes, there is essentially a reduction of GLP levels, so it makes a lot of pharmacological aspect to step up the GLP level so that it can impact upon the beta cell secretion of insulin. Why don't we have drugs for a GIP which can bring upon the GIP very efficiently? It is because of a very simple reason that there is something called as a GIP resistance, which is very difficult to break it. So it's similar to insulin resistance. So you don't have a drug which can break up the GIP resistance. So even if you step up the GIP levels, it will do no good in diabetes. So that's the point.
Sir, just a minute. Sir, Dr. Sahu needs to leave. Dr. Amal Kalra, sir, please understand.
Just a comment, sir. We may have some GIP sensitizers soon. Sir, we never know what will happen next. My last comment is, sir, this combination. I was reminded of film Dosti, the movie. One was blind, the other was not able to move. So it has a combination of both together are good friends, and this is the best thing.
I would request Dr. P K Gupta sir to summarize this wonderful CME for us. For me, Dr. Sunil Kapoor would put up the carry-home messages tomorrow in detailed way, and all of you would appreciate it. For me, the carry-home message point is, after metformin, if your patient is not adequately controlled, and if there is an underlying atherosclerotic vascular disease, what do you do to prevent those complications? Two complications are happening. One is the microvascular complications, other is the macrovascular complications. Okay, macrovascular peripheral arterial disease, MI and stroke. Okay, and then you have this complication for which we have invited Dr. Gulati sir today, the renal complication, the microvascular complication. For the first time in the history of any anti-diabetic molecule, after Empareg, we had this wonderful molecule which bridged the gap between microvascular and macrovascular complications. Right? And what is DPP4 inhibitor doing? We had these two wonderful trials, the Carolina head-to-head trial between inagliptin and sulfonylureas, and Carmelina. The first trial, we had a lot of trials on DPP4 inhibitors. The first trial, which had pre-educated, pre-specified renal endpoints and which demonstrated renal benefits. So when you combine two molecules, one which is taking care of microvascular complication, another which is taking care of macrovascular complications, makes a lot of sense to